Hello, my name is David Drullinsky. I'm an advanced cardiac surgery fellow in heart failure and mechanical support at Northwestern University in Chicago, Illinois, and I'll be talking today about heart failure and mechanical support. So we're going to be discussing the definitions, medical management of heart failure, cardiogenic shock, and what is durable mechanical support, and a little bit on heart transplants. So to start with heart failure, we're mostly going to be dealing with patients in advanced heart failure. Those are patients with severe symptoms that interfere with their daily life. It's also called refractory end-stage, stage D heart failure. We're going to see these patients have exercise intolerance, unintended weight loss, refractory volume overload, hypotension, signs of inadequate perfusion. They're going to be on maximum medical therapy. They're going to have repeated hospitalizations for it. And they have poor or worsening renal function, hyponatremia, hypoalbuminemia, and congestive hepatopathy, as well as elevated BNP. These patients usually are worked up with blood tests, basics and specific, chest x-rays that can show congestion or cardiomegaly, echocardiography that would evaluate ventricular function and other pathology, exercise test, if not contraindicated, and left and right heart cath when being worked up for the therapies we're going to discuss. Regarding diagnosis, this is going to be done in patients with optimal medical management, and they're going to have both severe symptoms and episodes of refractory fluid retention. There's going to be also objective evidence of severe cardiac dysfunction, like a decreased ejection fraction, diastolic dysfunction, right ventricular dysfunction, low index, and high cardiac filling pressures. They're going to have severe impairment of their functional capacity, either through a 6-minute walk test or other inability to exercise due to heart failure. Optimal medical management consists in beta blockers, ACE inhibitors, and mineralocorticoid receptor antagonists like aldosterone. Other therapies being used right now that are very widespread is Entresto, which is a combination of sacubitril and valsartan, and this is transitioned from an ACE inhibitor. And also ivabradine, that really helps with the heart rate, as well as CRT and ICD that will help improve symptoms. So what is cardiogenic shock? It's going to be a rapid decrease in cardiac function that can be caused by multiple insults, either ischemia, myocarditis, decompensated heart failure, inflammation, etc. These are the 2013 heart failure guidelines from the American Heart Association, and here we see patients that are recommended for inotropic support, mechanical cardiac support, and cardiac transplantation, and patients on cardiogenic shock are going to be class 1 indication for inotropic support or mechanical support. Here we can see all the indications for all these therapies. Here we see what are the recommendations for surgical percutaneous or transcatheter intervention treatments in heart failure. So in patients who have heart failure and need either CABG or PCI for revascularization that have a suitable anatomy, it is recommended to proceed. And here we can see all the rest that are 2As and 2Bs. The Intermax profile is important. It's important to know this. They can ask this, and it's scaled from 1 to 7. With the 1 being the patients who are critical in cardiogenic shock that are acutely dying. Intermax 2 is going to be patients who have a progressive decline. They're sliding down the slope, going up on inotropes and not thriving. Intermax 3 are patients who are stable, but they are dependent on their inotropes. They might be on a stable dose of milrinone or things like that. Intermax 4 are patients who have resting symptoms and they're on oral therapy at home. Intermax 5 is just they don't tolerate exertion. Intermax 6, they're limited in their exertion, but they're able to do some. and Intermax 7, they just have a New York Heart Class 3, but they're comfortable. In 2017, we had this Canadian comprehensive update on the guidelines for management of heart failure, and where we can see when mechanical support is recommended for patients who are listed for transplantation and who deteriorate or are otherwise not likely to survive until they find an organ. Also, it's considered for patients in whom there is a contraindication for cardiac transplantation, but with the mechanical cardiac support might survive. And also, it's recommended in patients on cardiogenic shock who are being considered for temporary mechanical cardiac support to afford an opportunity for evaluation for long-term options. That's it for that. There's not a lot of mention in the guidelines on acute mechanical support for cardiogenic shock. So ECMO is one of the tools we have in this kind of situations. It's extracorporeal membrane oxygenation. Most of you are probably familiar with it and have used it and know how to do it. But it's simultaneous mechanical circulatory support and gas exchange. The components, it's the inflow, the pump, the oxygenator, and the outflow. The pumps can be centrifugal or rotatory pumps. It doesn't have a reservoir. That's sort of the main difference with a cardiopulmonary bypass machine, although there are many others, like the lack of cardiotomy suction. So we're going to talk about a clinical scenario. We have a 25-year-old woman who's postpartum day 1, and she had a cardiac arrest on the ward as she was recovering. She had CPR, but she continued to be in pulseless electrical activity, no return of pulse, so ECPR code was called. That's an ECMO code. We arrived within the first 5 minutes, and she had 10 minutes of CPR by the time we showed up. Always on PEA in every pulse check. So what's the next step? So we decided to cannulate her and put her on ECMO, and it's very important to have a step-by-step formula. So we're going to talk about that. So we do peripheral ECMO for this kind of situations, for either ECPR or shock. Preferred approach is going to be the femoral artery and vein. We do our arterial puncture above the profunda, below the inguinal ligament, under ultrasound preferable, but may do without it. Currently we mostly do it with ultrasound. It might be even faster for us than doing it without. We use either a 16 or 18 French cannula. A femflex is our go-to, and we do it under Seldinger technique. We do the venous puncture at the same level, and we either use a 23 or 25, usually multiport femoral venous cannula, and we measure above the chest without touching anything before advancing. And we again use the Seldinger technique. We give heparin IV right before we cannulate. We do a wet-to-wet connection without a reservoir. There must be no air when connecting, because the air won't go to the reservoir. We unclamp and increase the flow until full flow, 4 to 5 liters. For heparin, we give about 5,000 units per patient. If there are really big patients, we might give 10,000, and then we start doing ACTs and we monitor according to that. It's important to have your own recipe. You might be asked on how would you put a patient on ECMO during the exam, and there's many ways of doing the same thing. So it's important that you know your way and you have it clear in your mind so you can state it step by step. So that's what we did. Here you see us cannulating this patient in an operating room, where I think where they were coding the patient. Great. So we put her on ECMO and we had great flow. Both cannulas are bright red though. Her blood pressure is still 20, and she's in levofed of 20 at this time, and she's flowing 5 liters. So what's going on? I think as many of you might know, it's important to know how to troubleshoot an ECMO circuit. It's not just putting the patient on it, but knowing what to do when things are not going your way, which in this kind of situations can happen. So what to do, or what could it be when each of these problems arrive. If you're unable to flow, it's because you have high pressure on your outflow. Why is that happening? Are you really cannulated on the right spot? Is your arterial cannula in a dissection flap, and that's why you're not really able to flow? Is there a clamp still on? These are things to check. Sometimes it sounds silly that there would still be a clamp, but check for that, because in a crisis situation you can forget. Are you unable to flow because there's slow return? Is your venous cannula well positioned? Is the patient, for instance, exsanguinated, and that's why there's no blood in the patient, so you can't really flow? Things like that to keep in mind. If you're on full flow and you have low blood pressure, is the patient really distributive shock, and that's why you're not able to achieve a good map? Is the A line on the right spot and able to really register the blood pressure? Does the patient have now a dissection that you caused with your cannulation? Are both cannulas maybe on the venous side and not really one in the artery and one in the vein? Is that why maybe both are bright red, because you're recirculating the blood and into just the venous system? What if both cannulas are dark? Is your oxygenator connected? This happened to me 2 weeks ago. Put a patient on ECMO, and both cannulas were black, and the connector from the oxygenator had popped out. It took us 5 seconds to recognize the problem, but it can be catastrophic if it persists. So it's important to check it. Same for both cannulas are bright. Usually you're recirculating, so whatever you're infusing in your arterial cannula is being sucked in by your venous cannula immediately, so there's a shunt, or usually you're in the same vessel, and that's why that's happening. So we recannulated the patient quickly. We had good flow, dark and bright red cannulas, good blood pressure, and off levofet. So we transferred the patient to the CT-ICU, and what are the next steps? So you can't forget about this. It's not just about putting the patient on ECMO, it's about knowing what to do after. The idea is to get the patient off ECMO. So you have to have a long-term plan. You have to know how you're going to anticoagulate the patient. You have to know if you need, and if you will do, and how will you do a distal perfusion cannula. Any complications that might arise, like a Harlequin syndrome, bleeding, low flows, arrhythmia, or effects on the ventricle, knowing if you're going to need to vent the patient or not, and also knowing when you're going to discontinue the ECMO, how to wean the patient, things like this. So this is a cath for that patient. We did a right heart cath and looked at her PA, and you can see there the large thrombus on the RPA, and we did a percutaneous thrombectomy with good results, and the patient recovered. Another scenario, we have a 58-year-old man with hypertension, dyslipidemia, who's otherwise healthy, who had a STEMI at an outside hospital, and he's in cardiogenic shock in the cath lab. He's intubated on inotropes with a femoral and aortic balloon pump, and is transferred to our hospital. He arrives in the CCU the next day. He's desaturating. He's on 80% FiO2, and he's having a fever of 38. His white count is 25. And in the outside hospital, it says it's likely the patient aspirated during intubation. So they send the information on the coronary anatomy, and we know he has a 95% left main, LAD of 75, circumflex of 60, and RCA of 70, with an ejection fraction of 35%. He was recovering, so they tried to extubate him in the CCU, where he had ST elevations. He became hypotensive and was reintubated right away. He was clearly septic after reintubation, and his ST elevations normalized though. So we have an intra-aortic balloon pump, but it's not enough. Do we have options how to upgrade? So this is what we ended up doing. We used an Impella, which is going to provide much better flows. This is an Impella 5.5. You can see there inside the left ventricle. A little bit after he was extubated, he stopped having fevers and his white count got better. So we did a CABG 10 days after we placed the Impella. We kept the Impella post-op you can remove it, but we chose to keep it, and we weaned it and removed it once the patient was extubated and off pressors. So what's the Impella? It's an axial flow pump which works with the Archimedes screw principle, and it goes takes the blood from the LV to the aorta. It's very effective at unloading the left ventricle. It can decrease the oxygen consumption in these ischemic hearts. There's many models depending on what you need, and they can be run with no or low anticoagulation for short periods of time. So it's better to control bleeding than other options. You may extubate and ambulate the patient with it when you do approaches like the right axillary approach, which we frequently do. This is a picture of different models, excluding the 5.5, which is not present there. And just a little bit of information regarding all the models. The Impella 5, you can get high flows, about 5 liters. Same as the Impella LD, which is one that's used just for surgery. You need a 21 French, so it's a pretty large bore. That's why we put it on the right axillary artery. We have to sew a graft to it, usually 8 or 10 millimeter graft. The Impella 2.5 and CP, they can reach about 3.5 liters of flow. CP can maybe get to 4 liters, and they can be placed completely percutaneously. So here's a picture of the Impella 5, all the different components. You have the inlet, which rests in the ventricle, and the outflow of the pump itself. It can flow up to 5 liters per minute, and it provides a console that lets you know about the placement, because it can measure the pressure in the aortic side, and if it drops too much, you know it's in the ventricle. And same thing with the ventricle. If it's too high the pressure for the ventricle, you know it's in the aorta. Impella 5.5 is one of the newer pumps. Also placed percutaneous, also placed through a cut down. It can flow up to 5.5 liters, and it has a very nice console that lets you know what's the LVDP, so you can really tell if you're unloading the LV well. Another option is Tandem Life. They manufacture a console, a pump, oxygenator, and cannulas. So this is a TandemLife Kit. It will have a priming tray, the TandemHeart pump, the TandemLung oxygenator, and the Protect Solo cannulas. So it depends on which kit you're using, what comes with it. Once we do TandemHeart, we're going to have a transeptal cannula, which is shown there in a second, and the arterial cannula, and you need to just do a transeptal puncture and deploy that cannula in the left atrium and the other one in the femoral artery, and you're able to do just left heart support. Or you can do the Protect Duo cannula, which goes through the right IJ into the PA, and thus you can do right heart support. You can have an oxygenator with it or not, depending if you're just doing RVAD or VV ECMO. Centrimag, it's a circulatory support system which is excellent, as well as a system of consoles and pumps, and you can use many different cannulas to cannulate with that. Another case scenario, a 62-year-old male. He comes in with a STEMI. You can see the lesions there. The LAD is the culprit. He was stented. After a thrombectomy was done with good flows, he was sent to the CCU. Post-op day 3, he had cardiogenic shock. They thought it was a stent, and they took him to the cath lab, but a post-infarct VSD was seen. They inserted an intra-aortic balloon pump, and he was stabilized, and the stent was open. So it's important to know what's the management of a post-infarct VSD. We don't see it often, but it's something that you have to know to manage. Patient stayed in the CCU with a balloon pump, no pressors, and he was extubated to 2 liters nasal cannula, and he was doing well. He was assessed by interventional cardiology, and they thought it was a good candidate for device closure. They took him to the cath lab and failed at device closure, so we took him to the operating room. He was too sick at the time for full repair, so we did a sternotomy and we placed mechanical support So we did a biventricular support with Centrimag. Post-op day 1, he desaturated with full ventilatory support. He had a pretty large pulmonary edema, so we connected oxygenator. Day 5 in the morning, we were rounding. For some reason, the RPM on the left support couldn't go above 4,000. The RVAD was working well. I was on call that day. I didn't really know what was going on. So what are the options? Well, I called the tech for the device, and he told me immediately we had to change the pump. So that's what we prepared to do. It's a indication of a device malfunction when you can't change the RPM. We got the new pump in the room, but before we could change it, the LVAD stopped. So what do you do then? Well, we did CPR and changed the pump quickly, and the patient was fine. So here's a little bit of a comparative table between all the other devices, and it's showing you what are the advantages and disadvantages of each one and what they achieve. It's an important table to memorize and understand. What about long-term mechanical support? So these are LVADs. They used to be pulsatile pumps. They were large, required extensive dissection, and now then there were continuous axial flow, the second generation. Now we're at centrifugal continuous flow, which are the current generation, third generations. The future is the totally implantable LVADs that are coming soon. The components: it's an internal pump, internal external driveline, external power source, and a control console. They're going to need lifelong anticoagulation, or at least while the pump is in there. Patient selection. So patients on cardiogenic shock with left ventricular function is unlikely to recover, and they're not good candidates for transplant, and they're too sick to be able to recover with a temporary mechanical support. These patients, if they have a capacity of recovery to a meaningful life, are considered for LVAD. If they're inotrope dependent, they should be considered for advanced therapies, including LVAD and transplant. Most of the times we do the evaluation for LVAD at the same time we're doing the evaluation for transplant. Then there's bridge to decision patients. Then there's bridge to recovery, bridge to transplant, and destination therapy. And these indications are not permanent. Patients who are bridge to recovery might not recover, become destination, or become transplant candidates, etc. It's a fluid diagnosis. It's important to recognize concomitant pathology. Patients who are reoperations will need CT scans for anatomy. Patients with congenital malformations might need an MR for anatomy. If they're having ongoing LV-apex MI, it's a relative contraindication and should delay the implant because that tissue won't be able to hold the LVAD. The aortic valve is important. You need to have a competent aortic valve. If there is more than mild AI, it should be addressed. If there's severe AS, it should also be replaced, given the capacity of recovery. Functional biological valves are okay, but if the patient has a mechanical valve, it has to be changed, since it will be spending most of its time in the closed position once the LVAD is turned on. For the mitral valve, severe MR, there's no contraindication. Most places don't really repair the mitral valve, but this is changing given the increased survival of these patients and many of them being destination therapy. It's unclear if there's a benefit yet. If there's mitral stenosis, that valve needs to be replaced or fixed. If there's a mechanical mitral, you can leave it, but a lot of people choose to replace it with a biological valve. If there's TR that's moderate or more, a lot of people consider it for intervention for repair. If there's endocarditis, the infection must be cleared. The device it's prone to getting infected, and if that's the case, it's very difficult to treat it. If there's ASDs or PFOs, this must be closed. And the LVAD alone in the setting of a VSD or free wall rupture is not recommended. This must be addressed. In patients with high BMI, they're high risk, but it can be done. Here are just some pictures of the technical aspects of LVAD implantation. This is the results of the Momentum 3 trial comparing centrifugal flow pumps with axial flow pumps, showing how the survival was over 75% at 2 years. Another scenario, 38-year-old woman with non-ischemic cardiomyopathy and EF of 15%, recurrent admissions for heart failure on inotropes and requiring pleural fluid drainage. She was sent to the clinic to consider for heart transplant. On her right heart cath, we see the numbers there with a PVR of 7 Woods units. Left heart cath, she was clean. She had severe TR, mild MR, no AI, EF of 17, no PFO. So what are the markers that are going to predict right ventricular failure? One is reduced RV contractile function. That's the formula shown there. And the CVP can be used instead of the right ventricular end diastolic pressure in the ICU. Elevated PVR, more than 5 Wood units, predict right ventricular failure after LVAD. And another marker is the PAPI, or pulmonary artery pulsatility index, which is calculated as shown there. More than 2 reflect a good function. Other parameters to consider before the LVAD is going to be the right ventricular function we just discussed, intermax status, renal function, hematologic function, pulmonary function, hepatic function, nutritional status, infection, GI bleed, and social environment. All these things are important and they must be addressed if altered. Another case in a patient who's high risk for RV failure. How do we prevent it? We can optimize oxygenation and acid-base state. That's going to help the RV. Reduce elevated afterload, like can be done with inhaled nitric oxide or albuminone. Aim for a CVP under 15. You can have kidney or liver failure from central venous congestion, and use inotropes as needed. So we transitioned the patient from the pump to the LVAD after we implanted it. These were the drips she was on. The LVAD was flowing 2.4 liters at 2600 RPM. It was a hardware, and the RV was mildly dilated. LV was decompressed in the septum towards the LV. Heart rate was 45, MAP 57, and PA pressure 21/11, and CVP of 20. So one thing we did initially that helped a little bit is we paced the patient at 90, and that helped increase the flows on the LVAD. The RV was mild to moderate dilated, the LV was decompressed, and the septum now is bulging towards the LV. So it's a little bit better. It could help, but in this case it wasn't enough. So we put a Protec Duo cannula which goes through the IJ into the PA, and another option to do is to do central mechanical support for the right heart. You can use a Centrimag and cannulate in the fashion that we see there in the right atrium and pulmonary artery. And this can be externalized so that the chest can be closed, or other times the chest can be left open. Another scenario, Protec Duo is weaned and the patient is decannulated post-op day 7 at bedside, SIM scenario. He's on minimal inotropes and discharged home on post-op day 20. We'll talk a little bit about heart transplant. It's the gold standard currently for advanced heart failure therapies. It requires a multidisciplinary workup to determine the candidacy, including general history, cardiac specific testing, screening tests, infectious disease screening. There's a lot of pre-transplant data that's needed, like blood type, antibody screening, HLA, DR typing, PRA screening, which is a panel of reactive antibodies, and 12-hour urine collection for creatinine clearance and total protein. The PRA is very important, and what it shows is mostly how the patient is going to react to the most common phenotypes out there. And if it's elevated, it means that it has a high probability to have antibodies with the donor, with the prospective donor. So cross-match is needed in those cases. So here are some contraindications. They're in the presentation. You can read them, but pulmonary hypertension is a big one. Ideal is going to be less than 3 Woods unit. Depends on where you read what's the exact number, but 3 and 4 usually. It's the limit. Other organ dysfunction, but they can be treated by multiple organ transplants. malignancies, life expectation that's low, or any of the other things shown there. Patients were sensitized, so we do ABO typing. They must be compatible. There's the anti-HLA profile and the PRA test. So it's going to tell us as I said, to what percentage of the population you have antibodies. More than 10% is considered high, and usually we do direct testing in these patients. There's ways to manage it. Sometimes they can normalize with time. Other times plasmapheresis and immunoglobulin are needed, as well as thymo, steroids, immunosuppression in general. There's some criteria here for transplantability, and there's different status in which the patients are listed. So here's a list of the status, so you can read them. So regarding orthotopic heart transplant, the idea is to limit donor ischemic time to less than 6 hours, but ideally it's less than 4. Coordination is very important between the donor site and implanting site. There's going to be variability depending on the recipient's prior operations and donor organs harvested. And implant is fairly standardized. There's 2 main techniques, biatrial and bicable. Right now, the preferred one is going to be bicable implant. This way, the atrium is more preserved and there's less arrhythmias. But you can read both techniques. Explant is complicated when patients have previous LVADs or previous surgeries. Key components of the post-op period are going to be atrial pacing. Many of these patients are in sinus arrest. Right ventricular failure is important as well if the patients have high PVRs. The right ventricle might take a hit because of the ischemia time, and it might take some time for it to adjust. So sometimes these patients need temporary mechanical support for the right ventricle. Immunosuppression is going to be key. Rejection and biopsies are important, and the management of the open wounds where the driveline was, where the axillary incision was, etc. Thank you. That's my email. If you have any questions, please feel free to email me. I'm happy to answer them. And good luck in the exam.